we're at the point now in the project where quality and metrics kind of kick in. And it's neat to see what neat, I actually mean it's really awesome to see what CHI can start to do. When we're at a point where you can do real PDSA cycles and continuous improvement, that's a great indicator that we are deep into operations and deployment, and planning is kind of in the rearview mirror. We're tweaking at this point. That's great. The other piece of quality reporting is very much tied to our collective financial health as an IDN. And most of you have a pretty good sense of this, but we wanted to take today to remind you of how we're funded. 3 years ago, the state, DHHS, cut a deal with the feds at CMS, and they said, we're going to do something a little different. It's a waiver, it's an experiment, and here's what we propose. You keep paying people the way you pay them, and we're going to put some extra money and effort toward getting all boats in the community to rise around a couple of fundamentals that are important to the whole country. One of those is shifting payment from fee-for-service activity-based payment to alternative payment models, also known as accountable care, also known as value-based payment, and a whole bunch of other buzz terms. Okay, so one of our explicit goals is to help move organizations toward that. And the second piece of this is they actually put us at risk. So our entire IDN is at risk for quality as we go. And it's been shifting over time under our feet. But as we go into 2019, 2020, we are fully at risk for starting to see improvement. Okay? So literally millions of dollars that we bring in to the region and to the state, because there's a state piece that's at risk and there's a region piece that's at risk. So what we wanted to make you aware that is happening here. So it's important that we be paying attention to quality. This year, 2018, has been, for those of you who've been following quality and payment reform, pay for reporting is a way to dip your toe in the water to move toward alternative payment models. Okay, so it's basically the premise is we don't care what you report. You could get a 0% on some measures, but we want you to have the capacity to figure out from your systems how you're doing on a few metrics, pull it forward, calculate those metrics, and report it to us. Okay? So that's what we've been working through with many organizations in the IDN this year, was getting you to a point where you could report. Monadnock Family Services are their most recent organization to come up on this, and they've done incredible work to get the measures that they're doing. Okay? There are 49 measures cranking away in the background. 7 of them are clinical. So those are the ones we are responsible for pulling out of your EHR systems. Some of you have really great EHR systems and it's easy, and we just pull it. Some of you keep switching your EHR system and it's really hard, okay? And some of you are on some systems that are great for behavioral health, but they don't think the way an NQ, our National Quality Forum metric, thinks. So the metrics are coming into collisions with reality, and we're doing our best to work through what is reasonable in those cases. We're here to help you do that. We're all working together to make that work. Okay? If we come out of this successfully in 2020, we'll have, and this is kind of my hope and dream, we can't switch to a more logical, aligned payment system in this country until quality works. Okay? If we can say to a payer, we're delivering this level of care, they can back off tracking all that activity that we've been doing. And slowly you can start to shed the years and years of fee-for-service and all the administrative overhead that you've been carrying for our lifetimes. Okay? That's the hope and the dream for this. So we'll help you. We've got people, we've got technology to help make this as easy as possible. In the background, the state and the MCOs are collecting all the claims and doing a whole bunch of the measures from claims. And they're also administering CAPS surveys. So there are surveys of patients' experience of care that are going in the background as well. Okay? So explicitly, you're going to see what we're measuring for clinical. Claims is going to take care of a whole bunch of activity-based reporting. CAPS will take care of patient experience. We show movement in a very hard to understand formula that they figure out at the state level that reports up to CMS. And then we get, hopefully, as much of that available federal funding as we can pull down. Okay. We're all in the same boat. This is the really good news slide. Okay? So I don't come to Carrie and Phil and say, here's how you're doing. It's how we are doing as an IDN. We are measured together. Okay? We provide a single numerator and denominator for each measure by IDN. Okay? So the first measure is how people are being screened. Okay? So if they're getting screened, Amelie's screening them when they do intake at Phoenix House, Carrie's screening them when they do intake at MFS, and or we catch them over, Eileen's catching them down at Cheshire. For that Keene area, we've got lots of angles to try to get great scores. During lunch, we talked about the issues with redundancy, and we will solve those, but we think we want to solve those second. But our first goal is really to make sure we screen together. Okay, so that's important to know, because there's some weird measures. There's a lot of primary care measures, and if you're sitting in your main role is to deal with mental health or substance use, you're probably, hyperglycemia might be on your radar, but it's further down your radar. So you don't necessarily need to perform well as an individual organization on something that's not in your core area. On the other hand, you need to make sure people are getting those primary care pieces done. So if you're the medical home for somebody, and we found this with West Central, where people just come to West Central, it's important, and they've realized this, that they need to get people over to get the primary care pieces and vice versa. Okay? So we can distribute how we do things because we're measured together. Okay? These are it's too small to read, but I want to give you what is it called? The cliff notes on what they care about in the contract. They care that we are screening and following up for substance use disorder, depression, smoking, intimate partner violence, high blood pressure, lipid disorders, and obesity. Right? That's one thing we're being measured on. Second, they want us to provide adolescent well care visits. Third, manage the chronic diseases within the behavioral health population. Those are the big primary care focus areas of high blood pressure, diabetes, COPD, and asthma. There's a lot of focus on reducing avoidable hospitalizations and readmissions. And this is where federally the focus has been for a long time too. They want people to send hospital discharges when people leave the hospital. You heard Jennifer earlier talk about those transitions with the CTI project that she's talking about. This is central to that. Want to prescribe opioids cautiously. And then there's some specific ones about managing med adherence and metabolic monitoring for patients with schizophrenia or that are using antipsychotics, and a general provide a good patient experience. 49 measures against those kind of 8 focus areas. But if we kind of agree that this in whole or most of this makes logical sense, the measures will take care of themselves as we go. Okay? So, all right, here are the people I want to thank for. Alice Peck-Day Primary Care is reporting. Cheshire Medical Center and DH Keene are reporting. Heater Road is reporting. DH Psychiatry as well. Monadnock Family Services, Newport Health Center, Valley Regional Hospital, Primary Care, and West Central Behavioral Health are all reporting, and this is a big lift, so please give a round of a hand. Counseling Associates in Phoenix House are right there next, and they've already started talking about this stuff. So, okay. So in a nutshell, we are all at risk for money to bring in. We're all at risk for in the same boat. We have a logical set of things that underlie our programs, and we will help you wherever you need help. I know I stand between you and the door, so if you have any questions that have nothing to do with consent, I will answer them. So, yes, Eileen.
So, Mark, I appreciate the clarity that we're all in it together. And so ultimately, as a region, we are going to be judged on our performance by the collective we. I think there's an opportunity, perhaps, because I would make the assumption that we are not all at an equal place of how we're doing it, that some of us are learning some are having challenges. And so I wonder, is the opportunity for, and I guess I'd look to you since you're sort of enmeshed in it, to be able to identify the organizations that are doing it really well, and what systems they have in place to do that, and how do we share those wins? So not calling out the people who aren't doing it, but rather highlighting the people who are, so it's like we can all learn from that.
Yes. I love it. That's exactly what we hope to do. And it relates to what Marcy was presenting too. And I guess it's cross-pollinating, and that's one of the jobs of the IDN, is to be aware of where things are going well and to be able to pull forward what we can learn from those things. The Data and IT and Quality Work Group meets monthly. That's another house for this that meets for a lunch and learn at the last Wednesday of every month. So a lot of the quality champions within your organizations attend that. And that group is also recommended that we do. They haven't formalized that recommendation, but I think there's desire to have some transparent sharing. Much like you saw some lines with the CHI assessments, but to be able to openly say, here's how we're doing on this particular measure. We're a substance use disorder treatment, and our HbA1Cs scores are really low. No, I'm joking. But we're in this boat, but we're working with this partner to bring these collective measures up. So I like the idea, and we're committed to doing that. In time, we're in right in the beginning, where we're just getting the numbers.